Bismillah Rahman Rahim. Assalamu alaikum. Dear colleagues and dear PGs, today we shall discuss that after starting a patient on antiviral treatment, how we define the response, what response is expected, and how we categorize our patients according to the response, because this is very important to see whether our patient is responding or not. And if unfortunately our patient does not respond, then how to go about that. So the discussion is about in chronic hepatitis B patients, how to evaluate the response to antiviral treatment. I already recommended that EASL guidelines are the basis for these presentations, and we have understood now the difference between hepatitis B and hepatitis C, and why there is so much specific discussion about the hepatitis B, because it's a nucleic disease, only controllable, AVT net indicated in each and every patient, and once started, it's a lifelong antiviral treatment. We did discuss in the previous videos the 4 steps algorithm. In the first step, to evaluate the liver status; in the second, viral load; in the third step, serum ALT levels; in the fourth step, other factors. And we discussed what should be the criteria of viral load and ALT for cirrhotic liver, fibrotic liver, and normal liver. And if there is any deviation like normal ALT, then what should be the criteria to start antiviral treatment? And if there is the DNA levels is less than the required criteria, then when we will start these patients on antiviral treatment. Then we discuss the options of the antiviral treatment for these patients, and after starting these patients, how we monitor the antiviral treatment for its efficacy, for the safety, and for the liver disease status. This is we have discussed till now. Today we shall discuss that once we started the patient on antiviral treatment, how we evaluate the response, how we define the response. So this is the response categories. This is the virological response on treatment, and this is the virological response of treatment. If we have stopped the antiviral treatment, which is done only in the very few patients, then what is the serological response, what is the biochemical response, and what is the histological response, and what should be for the NA therapy if the patient is on oral drugs, and what if the patient is on pegylated interferon. So before coming to these virological responses, the histological response is defined as decrease in necroinflammatory activity without worsening in fibrosis compared with the pre-treatment histological findings. If biopsy has been done, so you compare the on treatment and after, if you stop the treatment, then you can compare, and the histological response will be defined decrease in the necroinflammatory activity, because on biopsy we see the necroinflammatory activity and the fibrosis activity. So there should be decrease in the necroinflammatory activity, and there should be no worsening in the fibrosis compared with the pre-treatment histological findings. The biochemical response is defined as the ALT normalization, and it is confirmed by ALT determination at least every 3 months for the first year post-treatment as well. So ALT should be normalized and remain normalized on treatment and after the treatment. If you stop the patient, the AVT has stopped in any patient. The serological is of 2 types. One is the E antigen serological, one is the hepatitis B surface antigen serological response. For E antigen, this is the loss of the HBe antigen and development of the anti-HBe. And for the surface antigen, this is the loss of the surface antigen and development of the anti-HBs. So the HBe antigen seroconversion and HBs antigen seroconversion, these are the serological responses. We do know that with the current therapy, the HBs antigen seroconversion is very rarely achieved. And so now coming to the virological response, the DNA responses, how is that? The virological response, first, it's on treatment, it is different for the oral therapy and for the pegylated interferon therapy. For pegylated interferon therapy, it is simple that on treatment, the DNA level should drop to less than 2000 international units. I have discussed these values in detail in my first video on the hepatitis B. So the pegylated interferon response is if the DNA level falls lower than 2000 international unit. And sustained response for pegylated will be that off treatment that the DNA remains less than 2000 international units for more than 12 months after the end of therapy. So if you had started a patient with pegylated interferon, so on treatment, checked 6 monthly and then 12 months, the PCR should have dropped less than 2000 units, and then you will see the patient has achieved the response or sorts of end treatment response has achieved. And then you follow these patients without interferon for the next 12 months at least, and the PCR should remain less than 2000 units. Then you say that probably the sustained response has achieved in that patient, but it is not the end of the story. You keep on checking these patients because we have seen the relapse, and the later relapse is not uncommon. Coming to the oral therapy, if you started a patient on the oral therapy, the response is defined as when the DNA level is less than 10 units per ml. You see, for pegylated, it was less than 2000. For oral, it is less than 10 units. This is called response, or response has achieved on treatment. If there is less than 1 lag decrease in the HBV DNA after 3 months of therapy, you started a patient on antiviral treatment, and after 3 months, we checked the viral load, and there was less than 1 lag decrease. You call this primary non-response. So this is the primary non-response. One is patient has not achieved the response, and it is not the non-response, it is in between. So that is the partial response. And the partial response is that the DNA is decreased by more than 1 lag, but still detectable after 12 months of therapy in compliant patient. And the patient is compliant, patient is taking drugs, and 12 months therapy has completed, and there is decrease of more than 1 lag, but still the PCR is positive. So you call this is a partial response. And there's a breakthrough response, and it is that the DNA increase of more than 1 lag above on therapy nadir, and this we will show in the diagram over here. So you started, this is the DNA levels, this is the duration in months. So the response will be that you started a patient on antiviral treatment and the concentration went down. It became less than 10 units undetectable, and it remained undetectable after 12 months of therapy and even after that. So this will be the response has achieved. One will be a primary non-response, that there is a decrease, but not then it is less than 1 lag. Initially it was 6 lag, but still it is 5.3 or 5.4 lag, and it remains like that. So this is called primary non-response. One is partial response, and this is the partial response, that the DNA level has dropped down, but it's more than 1 lag. You see, initially it was 6, and now it is around 2, but still it is positive, and it remains positive. So this is called partial response. And the breakthrough is that the PCR went down, it was less than 10 units undetectable, and it remained for some time, but then there's increase of more than 1 lag. Like see here, it was less than 10, but then it is rised again. So this is called the breakthrough. So this is the way how we define the response to the antiviral treatment, whether our patient has achieved the response, or the patient has not achieved the response, or the patient had achieved the response, but then a breakthrough happened, or the patient has got partial response. These responses, they were more important, and we saw these more frequently when we used to treat these patients with the initial oral drugs like lamivudine, like adefovir, like telbivudine. Those were the drugs when these responses we used to see them. With the current therapy, entecavir or tenofovir, mostly we see the patient with response, or sometimes the patient is not compliant, then there may be a breakthrough. But the on treatment in compliant patient, the non-response and the breakthrough or the partial response, they are very rarely seen. This is a very important slide that what is the cure with antiviral therapy. This is the acute hepatitis B patients. In acute hepatitis B, we know the surface antigen is positive, E antigen is positive, and the DNA PCR is positive, and the cccDNA is also positive. These are the 4 parameters. And if the patient recovers within 6 months, well, okay, when there is the H-base antigen goes away and anti-H-base appears, E antigen goes away, E antibody appears, DNA becomes negative, but still the cccDNA is there, and then we call the patient has recovered from the acute hepatitis B. If the patient does not recover from acute hepatitis B and patient enters into the chronic phase where the S antigen is positive, E antigen is positive, DNA is positive, and the cccDNA has to be positive because now it has entered the nucleus. So with the current therapies of the chronic hepatitis B, what we get in most of the patients, the partial cure. And by partial cure, we mean that the DNA, cccDNA is positive, but the HBV DNA PCR becomes negative. The E antigen seroconversion happens. The E antigen goes and the antibody comes, but surface antigen, HBs surface antigen, remains the same. So the partial cure is that your therapy has resulted in the DNA loss, the HB antigen seroconversion, but the HBs antigen remains positive, and of course the cccDNA is also positive. We don't check cccDNA in clinical practice, but in these patients, this is positive. So this is called partial cure. And in most of the patients, when we say our therapy has been able to control the infection, or it is successful, by successful means that we have achieved the partial cure. There's another term, an advance of this is the functional cure. Functional cure is the partial cure, and on the top of from the partial cure, you remove the HBs antigen. So in this, DNA is negative, E antigen seroconversion has happened, and now the HBs antigen has lost with or without the anti-HBs appearing. So in the functional cure, and this is still it is when we achieve the functional cure, it is a sort of very, very great success, because we rarely see functional cure with the current therapies. If we want the patient should have a complete cure, by complete cure we mean that the cccDNA should also go away. With the current therapy, the complete cure is not possible. Complete cure will be when surface antigen becomes negative, E antigen becomes negative, DNA PCR becomes negative, and the cccDNA also is cleared. The hepatocytes nucleus is cleared of the cccDNA. And if this happens, we will call complete cure. But for getting complete cure, we are looking for the future for the upcoming therapies. And we hope that in the upcoming therapies will be able to give us the complete cure. In the coming videos, I will be discussing what are the upcoming therapies, what are the drugs therapies in pipeline, and when we expect that they will be in the markets. So, my dear colleagues, today I wanted to discuss with you that how we define the response, and what is the desirable response, what is the non-response, what is the partial response, and what is the breakthrough. And then we discussed that the cure, what do you mean by cure, what is partial cure, what is functional cure, and what is complete cure. With the current therapies, we can go till the partial cure or functional cure. We cannot achieve the complete cure with the current therapies. For that, we are expecting in the future to be for the upcoming therapies where the functional cure, complete cure will be possible by clearing the hepatocytes from the cccDNA. So I hope I was clear to define the response and how to evaluate the response. Inshallah, in the next video, we shall see the why we need to treat the antiviral patients with antiviral treatment. What is the rationale behind? If we don't treat these patients, what happens? So till then, it's Khudafis. Inshallah, see you in the next video.